members of the Oman Pharmaceutical Society from different sectors, including hospitals, pharmacies, industry, and academia. A warm welcome from the College of Pharmacy at the National University of Science and Technology. We are extremely delighted today to host the Pharmacy Club session that is co-organized with Oman Pharmaceutical Society. Today's session will include 3 topics. One by Dr. Yaman Qassab from the College of Pharmacy, National University. Another by Dr. Kannan Omar from the College of Pharmacy, National University. And the third by Dr. Arif from Sultan Qaboos Comprehensive Cancer Care and Research Center. The session will be moderated by Professor Alka Ahuja, which is the Assistant Dean for Academic Affairs in College of Pharmacy, National University. However, before we start, I would like to highlight an important point. At the end of each presentation, please take the time, as you'll find a QR code, so take a moment to scan it and share your feedback on today's presentations. Your opinions and comments are valuable for enhancing future Pharmacy Club sessions. Additionally, I encourage everyone to scan the QR codes on the roll-up stand in the front hall for a chance to participate in giveaways, also known as the prize draws. Let us start. We shall start our session by the recitation from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان.
صدق الله. And now, I welcome Pharmacist Haifa Raisi, member of the Oman Pharmaceutical Society Board, for the opening.
السلام عليكم ورحمة الله وبركاته. الحمد لله الذي علم بالقلم علم الإنسان ما لم يعلم والصلاة والسلام على سيدنا محمد سيد البشر وعلى آله وصحبه أجمعين. The respected doctors and pharmacists from all various specialties, the creative pharmacy students, dear attendees. It is my pleasure to welcome you to this distinguished and renewed pharmaceutical event from the series of Pharmacy Club sessions, of course in collaboration with the National University of Science and Technology, and of course with the support of GSK Pharmaceutical Company. We extend our sincerest thanks and appreciation to them. Thank you, GSK. Before we start our event, I would like to take a brief moment to highlight the significance of professional pharmacy organizations such as Oman Pharmaceutical Society, which aims to educate, support, and bring together its members within a shared professional framework. Oman Pharmaceutical Society acts as a fundamental support of the pharmacy field, bringing together pharmacists and students who are committed to progressing pharmaceutical science, education, and practice. They promote the safe and appropriate use of medicines, offer leadership for the profession, encourage continuous professional development, and create opportunities for collaborations. This, of course, will enable pharmacists to provide patient-focused care and enhance health outcomes globally. Becoming, of course, a member of Oman Pharmaceutical Society links you to an active community dedicated to advancing the future of pharmacy and bettering public health. Finally, I hope that the presentation will be engaging and rich with valuable scientific information, and the whole entire event will gain your satisfaction. Thank you very much.
Thank you, Pharmacist Haifa. Now, I would like to invite Professor Alka Ahuja on the stage to moderate the 3 sessions. However, please allow me to briefly introduce her. Professor Alka Ahuja is a professor of the Pharmaceutics and Assistant Dean for Academic Affairs at the College of Pharmacy, National University of Science and Technology, which is in Oman. She also chairs the Research and Innovation Committee. A gold medalist with nearly 40 years of teaching and research experience at Jamia Hamdard in India and NUST in Oman, she has significantly made contributions to mucoadhesive and nanotechnology-based drug delivery, as well as health outcomes research. Professor Ahuja has delivered invited talks worldwide and presented more than 200 research papers. She has led over 20 major research projects, developed several postgraduate programs in the National University, and supervised more than 100 theses. Her scholarships included over 260 publications with nearly 13,000 citations, 12 authored books, an edited volume with Springer, patents, and editorial board roles. Among her many honors are the University Gold Medal, the IDMA GP Nair Award, the AICTE's Career Award for Young Teachers, Asian Education Leadership Award, Global Education Leadership Award, and NUST's Academic Excellence Award, as well as the International Achievers Award, to name it. Now, I would like to welcome.
Assalamu alaikum and a very good evening to all of you. I would like to thank Oman Pharmaceutical Society for giving us the opportunity to host, along with the Oman Pharmaceutical Society, this pharmacy club today. And I would like to briefly introduce our first speaker for the session, Dr. Yaman Walid Kasab. He is an assistant professor in pharmacy practice at the College of Pharmacy, National University of Science and Technology. He holds a PhD in clinical pharmacy from Malaysia, where his research focused on pharmacist-led interventions in secondary prevention of coronary artery disease. Dr. Kasab has over 15 years of academic, clinical, and research experience across Oman, Malaysia, Jordan, Iraq, and the UAE. He has taught extensively at both undergraduate and postgraduate levels, covering clinical pharmacy, pharmacotherapeutics, public health, research methodology, etc. He has played leading roles in curriculum design, accreditation, and academic quality assurance. He has supervised more than 60 undergraduate research projects, over 30 postgraduate projects, and successfully graduated 3 PhD students. His research contributions include 82 peer-reviewed publications, several book chapters, and a Scopus H-index of 12. His areas of interest include cardiovascular pharmacotherapy, polypharmacy, patient adherence, pharmacoeconomics, and pharmacy education. He is a certified GCP practitioner and holds qualifications in healthcare management, teaching methodology, and advancing pedagogy. He is an active member of several professional bodies, including FIP, the Oman Pharmaceutical Society, and the International Society of Oncology Pharmacy Practitioners. With these few words, I would like to invite Dr. Yaman to address the audience, and he's going to speak about bacterial resistance patterns in tertiary healthcare facilities in Western Oman. Dr. Yaman, please. Thank you.
Assalamu alaikum and very good evening to all of you. It's my honor. Am I clear? My voice clear? It's my honor to stand here today with you to share some of our recent research that we done recently. I would like to thank Oman Pharmaceutical Society for giving us the chance to share our research with all of you and share the experience all together, inshallah. The project that I'm presenting today is called Antibiotic Resistant Burden in Western Oman. Okay, so this is a part of a recent project we finished together with my team in Western Oman, Al Brahmi Hospital mainly, and the surrounding 9 healthcare centers. The reason I chose this project to present, because as we know, as a pharmacist, our main role is to ensure the rational use of medications. And of course, antibiotics is one of the main areas where always considered a challenge using such kind of medications. And as we know that the burden of antimicrobial resistance is keep increasing day after day. And another reason is, as we know that this week, this day actually is the last day of the antimicrobial resistance awareness day worldwide. It's from 18th to 24th of November, so today is the last day. So I thought this is a good, in line with this week, I can present our finding here in Oman. When we talk about antimicrobial resistance, we all know that it's considered one of the major healthcare issues, not only locally, but worldwide, as we know. And according to the WHO, AMR, or antimicrobial resistance, is considered one of the top 10 global public health issues. Okay, so, and we all know how common is and the impact of such problem that can lead to, as we said, mortality, morbidity, increasing the cost of healthcare management, and of course will lead to failure of therapy, more hospitalizations, more cost, and so on. Okay. Just a brief background. Globally, if I ask, do you think antimicrobial resistance is common worldwide? Definitely. So, and the numbers are keep exaggerating and increasing, not year by year, but month by month. And I can confidently say that at this moment, as we know, since I think more than 15 years now, no more new antibiotics come into the market. And then, so we stuck with whatever antibiotics that we have. Okay? So globally, just to share, this one in 2019, antimicrobial resistance itself lead to or was associated with nearly 4.9 million deaths in 1 year. And then out of those 4.9, direct association was 1.7 million deaths in 1 year. In terms of cost and the estimation in the coming 2050, the estimation said in 2050, it's estimated to be like 10 million deaths to be caused by the resistant pathogens and failure of antimicrobial therapy. Cost-wise, estimated that failure of this antimicrobial therapy can lead to up to 66 trillion euros or franc Swiss per year we are talking. So from the figures, you can say how major this issue is, and it keeps spreading. So we as a clinical pharmacist or as a pharmacist in general, we have a key role to stop or to try our best to rationalize the use of antimicrobials, to try our best to stop and at least control and maintain the resistant patterns for microbials, for different organisms. In Oman, evidence is still lacking, no much studies done. So that was the main rationale for us to start such kind of study. So we started in Western Oman, and our objective was to look at the distribution of bacterial pathogens. What are the common pathogens? What are the common antimicrobial usage pattern? What the common susceptibility or resistance pattern, okay, in from different hospital settings, inpatients, outpatients, referrals, and so on. Briefly about the methodology, it was a retrospective cohort study, cross-sectional study done in Al-Brahimi Hospital and the referral centers, a total of 9 centers in Western Oman. It took over 1 year, so we collected the complete data over 1 year. So we didn't do sampling, we just took all kind of clinical isolates, okay, isolated in the hospital, to find out what is the pattern of resistance and so on. So a total of 9 healthcare facilities were included in these studies, okay? The period of study, it was from January to December 2024, a total of 3,592 isolates were included. So this is the whole isolates that were tested over the 1 year. We took all kind of samples, urine, blood, wound, respiratory samples, tissue samples, fluid samples, and so on, all from all departments and all referral centers, those 9 settings, as we said. We excluded all duplicate isolates, any contaminated isolates, or any incomplete or missing data were removed. Briefly about the results. So a total of, as we said, 3,500 samples were included, belongs to both males and females from different ages, from different age groups. So female were predominant, not much, but like 60% were females of the samples, and the remaining were males. The patients included were in the middle of 40s, but we included all age groups, infants, children, adults, geriatrics, and so on. And then we subcategorized them to find out if there is any differences. All settings were included, so outpatients, inpatients, different kind of wards, as you can see, even referral cases from other surrounding primary care centers, polyclinics, and so on. Okay, because Al-Brahimi Hospital was the main referral center, so all surrounding centers and clinics were referring to that hospital. Again, all kind of samples were included in this study, urine, blood culture, wounds, even the line and catheters, fluids, synovial fluids, fungal samples, and whatever. So all were included. Okay. Just to share the findings, let me start first with the main issues when we talk about antimicrobial resistance or antimicrobial treatment in general. So as we know, the general rule says that you have to start empiric therapy as soon as possible and then do the cultural test as soon as possible in order to know how to de-escalate your therapy, right? So can you guess the guideline says when should we take the culture and sampling? It should be taken when? Ideally, as soon as possible. So it should be on day 1 of admission, okay? So the result shows here, the mean time of testing was 4.3 days with a range of reaching up to 9 days. So you can say that there is a delay in the time where the culture and sensitivity were taken. So only 29% of the tests were performed on the same day, and 43%, sorry. Okay. And 43.9% were done within 2 to 5 days, and the remaining even more than exceeding 5 days. And no need to say that we can guess what kind of implications this will lead to. So this will lead, I can say that a prolonged use of the empirical antibiotic therapy, This can lead to longer hospitalization, more risk of resistance, more risk of failure, and so on. Okay? With regards to the organisms isolated, so gram-negative were the dominant, which represent 58% of the whole isolates. Gram-positive represented 30%, and fungus and fungal and yeast were accounted for 11.3%. Of the gram-negative, E. coli, Klebsiella, Pseudomonas were the top, and from the gram-positives, Staph, Strep, and Enterococcus were also the top. Fungal and yeast, Candida, of course, is the leading one. Let's go more deep of the findings. So we studied one by one. So we start with the gram-negative pathogens. Klebsiella, as we said, was one of the top. So a total of 476 isolates. And then Klebsiella pneumoniae were the dominant one. With regard to Pseudomonas, again, a total of 261 isolates. Pseudomonas aeruginosa was also the top. With regard to gram-positive, Staph, there was a total of 542 cases, and Staph aureus was the most prevalent. With regard to Strep, a total of 447 cases, and then with different, species. Let's jump to MDRO, multi-drug resistance. When we say multi-drug resistance, it comes to our mind different related terminologies, right? So when you hear multi-drug resistance, what is the meaning of multi-drug resistance? Multi-drug resistance, right? From the name. Okay, but if I ask you now, how many antibiotics I'm talking about? 2, 3, 4. So to consider as a multi-drug resistance, that bacteria or that organism should be resistant to how many of them? This is the question, because there are different terminologies related. So when you talk about MDRO, just let me share with you again. So we are talking about a minimum of 3 different antibiotics from different groups. Okay. So this is MDRO. So the findings, the total cases with MDRO or the total isolates were 782, which made up to 21% of the isolates. So roughly 1/5 of the isolates were MDRO. And then I will leave the figures talks by itself, how serious the problem is. The most common ones were extended spectrum beta-lactamase, MRSA, and CRE as well. Then we studied the organisms one by one to see the resistance profile of different gram-positive and different gram-negative pathogens. So for example, let's start with the Staph. So overall, most of Staph aureus isolates remain susceptible to the commonly used or the commonly recommended by the guidelines, which is a good sign. So at least the resistance pattern for this bacteria is not that much. So 100% susceptible for augmentin, meaning we still can continue with augmentin. The high resistance rate were regarding ampicillins, oxacillins, Clemda as well, and so on. So we have to be careful to rationalize the use in order to at least try our best to stop the spread of the resistance. With regard to MRSA, so also good sign. It showed a high susceptibility to vancomycins and linezolid, which is also like good findings so far. And definitely augmentin. Can we use augmentin for MRSA? Definitely no. So that's why the figure explains why it's 100% resistant. Okay. With regards to another gram-negative, which is Acinetobacter baumannii, which is one considered a severe microorganism, gram-negative microorganisms, and it's known by its nature to be a multi-drug resistant. So the resistance was the highest against tazocines, And as you can see, the red represent the resistance rate. So the highest was for tazocine, meropenem also 74%. You are talking about 3/4 of the isolates were resistant to meropenem. Okay, and amikacines, cotrimoxazole, gentamicins, and so on. Another pathogen commonly isolated was E. coli. And this represent, it indicates that a lot of UTI cases were also recorded. And this E. coli shows high susceptibility to most antibiotic tested, which is a good sign. However, ampicillin was the highest resistance rate. Ciprofloxacin also from quinolones also showed some reduced susceptibility. Okay. Another Klebsiella pneumonia, gram-negative as well. So you can see that this bacteria showed extensive resistance. Out of the total Klebsiella pneumonia isolates, 21% were ESBL, and carbapenem resistance were representing around 19%. Okay, if we break it down, so extensive resistance across most of the antibiotics, which a warning sign that this trend has to be stopped because it's really dangerous. So you can see, for example, cotrimoxazole 100% resistance, some cephalosporins as well, also 100% resistance. So stewardship is a must here. With regard to Pseudomonas, and we know how serious Pseudomonas is, so with regard to Pseudomonas, also show high resistant rate among most of the antibiotics tested. Ceftriaxone and oxacillin has the highest resistance rate, but amikacin is a good hope. The resistance rate was only 0.8. So it's considered the most reliable options so far. And this is put us in a difficult situation where we have a narrow treatment options remaining to treat any infection with Pseudomonas. Another objective of the study also to look at the prescribing trend of the antibiotics. I'm just sharing one group here, which is the prescribing rate of cephalosporins. So a total of 3,700 prescriptions contain cephalosporins with different generations. Third generations was the dominant, accounting for majority of the use. So third generation cephalosporins is the most commonly used. So of course this reflects the high resistance rate. To summarize and in conclusion, gram-negative was the dominant. Among those, a lot of MDROs, which represent 1/5 of the isolated cases. Resistance rate was high across different classes of antibiotics, and we are talking about cephalosporins, quinolones, even meropenems, and different, like the advanced classes are also showed high resistance rate, which tells us that we need to wake up. This is a wake-up call that we need to rationalize the use of antibiotics. Antimicrobial stewardships is a must. Yes, most of the hospitals recently started doing antimicrobial resistance, but the question now is whether this stewardship is evaluated, how effective is it, and whether it's run in a correct way or not. This is the next future studies. Recommendations, of course, we have to be careful of the timing when we take the testing. So we should take it as soon as possible. We have to strengthen the stewardship programs, implement more strict use of antibiotics by implementing automatic stop orders, by involving the microbiologist more and more, okay, to control the prescription and to make sure that they approve or allow, or they have the final call before the prescription is allowed to be dispensed. And then, of course, education, and awareness is the key term here. With this, I end, and thank you very much.
Thank you, Dr. Yaman, for an excellent presentation. And as mentioned by him, that it is one of the most challenging situations which is faced in many hospitals. And recently we also had a research symposium where the speakers, they talked about its application and how they are trying to control this in different hospitals, including in Sohar Hospital, Khawla Hospital, etc. So thank you so much. It's really alarming, and we all need to together do something about it. So we have our next speaker, Dr. Kanan Omar Ahmed, who is going to speak on clinical pharmacy services for patients with heart failure in limited resource settings, a practical experience. I'll briefly introduce Dr. Kanan, who is a certified, who is an assistant professor in the pharmacy practice department at the National University of National University of Science and Technology. And he was the former Deputy Dean, College of Pharmacy in the University of Jazeera in Sudan. And he was also an Associate Professor of Clinical Pharmacy in Sudan. And he has total of 21 years of experience in different pharmaceutical fields and 15 years of clinical experience as a cardiology clinical pharmacist specialist. He worked in Sudan and Saudi Arabia. He has 10 years of teaching and supervising MSc and PhD candidates in clinical pharmacy. He has a strong research profile with approximately 40 publications in the cardiovascular therapeutics. So we are looking forward to listening to him and understanding his experience in the field of heart failures. Dr. Kanan, please. Thank you.
طيب بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته and good evening for everyone. First of all, it is my pleasure and honor to be here inviting to give a short presentation about my project or my dreams in Sudan, and it is talking about the clinical pharmacy service in patients with heart failure in a limited resource setting. It is an practical experience. So during this presentation, I only give about the during this short presentation, I will just touch this issue, introduction about heart failure, and then prognosis and of heart failure treatment pillars. Don't worry, it is a short touch, okay? And what is the disease management program, and what is the philosophy of heart failure clinic, and also first heart failure clinic in Sudan. And finally, I'm summing my talk with heart failure clinic publication and take home message. So first of all, I think all of you know that the heart failure is a complex clinical syndrome caused by either structural or functional abnormalities of the heart, and it is the end there is no sufficient blood pump to meet the body metabolic need. But you can see this is an alarming issue here. So you can see, despite the medical and device therapy for heart failure is associated with high morbidity and high mortality and significant economic burdens to patients, families, and to the health system as a whole. So there is a lot of advances in patients in treatment of heart failure with a medical or device therapy. But despite all these issues, the hospitalization and the mortality is quite alarming. And you can see here from the statistics, there is now 26 million people worldwide suffering from this disease. And the prevalence will be estimated to increase by 20% on 2030, which we are not far from there, okay? And according to the Heart Failure Society of America in 2023, there is a jumping from 6.7 million to 8.5 million, almost 2 millions prevalence in heart failure in just in US. So now this is quite astonishing slides. So you can see the mortality of heart failure. The mortality of heart failure is worse than 6 types of cancer. Unfortunately, there is some of colleagues today from the oncology. So you can see here on the breast cancer, 10% on Hodgkin and non-Hodgkin lymphoma, and then up to leukemia is a 40%. While the mortality for heart failure after 5 years is 50%, which is a quite alarming issue. This is despite the advance in therapy in what is medical or device therapy. And also, hospitalization due to heart failure, it's also quite alarming. You can see about 44% of patients readmitted within 6 months, and 25% of them, they are readmitted within 30 minutes. And you can see here, just in 2013, there is 1 million Americans hospitalized due to the heart failure, which is a quite, I think, horrible statistics. 1 million people in 1 year just hospitalized due to the heart failure. So, in a quick, there is different classification system for heart failure. It can be just classified either systolic or diastolic or whatever it is. But the most clinical classification of heart failure is based on the functional capacity of the heart. So the heart failure based on the ejection fraction, it can be classified to the 3 types, whether heart failure and reduced ejection fraction, which is ejection fraction less than 40%, and heart failure with preserved ejection fraction, which is ejection fraction more than 50, and there is heart failure with mid-range, which is 40 to 49. And our all project is done on the heart failure and reduced ejection fraction. So there is a problem in the pump in the heart. There is a problem in the contractility of the heart. So, and all the guidelines and all the clinical trials is done towards the heart failure with reduced ejection fraction. And just, we can say in this presentation, we can say is a HFrEF. So our topic is just working about the HFrEF. So I think all of you know there is a pillars to treat the heart failure. So we have 5 to 4 pillars based on the guidelines, whether American or the European schools. So we have ACE inhibitors or ARBs or angiotensin receptors blocker inhibitors. This is a new medications which included Entresto, valsartan, sacubitril. And we have also beta blockers. We have MRAs like spironolactone and eplerenone. And we have the new game changers, which is SGLT2 inhibitors, including dapagliflozin. And in fact, this treatment, I think all of you know, it is basically used for diabetes, but now it can be used to treat heart failure, whether patient diabetic or without diabetes. Okay? And there is a rule here. Those pillars, they can reduce the mortality and hospitalization when they are used on the target doses. So for all of these medications, there is a target dose that should be used during the practice. So for example, if you start talking about lisinopril, one of the ACE inhibitors, the target dose to reduce the mortality is 35 milligram. Whether in the practice, you can see a lot of differences. Also, you can see if you want to change or to reduce the mortality and hospitalization by using bisoprolol, so you have to achieve a dose of 10 milligram per day. If you use it 2.5, so this is a loss of practice, and this is a loss of money, and also this is decrease the all the outcomes that we can need to achieve during the treatment of heart failure. So this is the main issue. So you have to use this pillar to reduce the mortality on a target doses. And this is a quite challenging in the real setting. Okay, so why I choose heart failure to do a surface? Why we choose heart failure? There is other cardiovascular disorders. We have hypertension, we have dyslipidemia. Why we choose heart failure? So the heart failure or HFrEF in the clinical practice uh, or in the guidelines, there is a good outcome in the guidelines. So the treatment decrease the mortality, decrease the hospitalization in the clinical trial. While in the real setting, there is a poor outcomes. Okay? So the mortality you see, 50% after 5 years, and the hospitalization is 44% after 6 months and 25% after 30 days. So this is during the usual care. So the usual care is mean that the patient is just treated through one person, through a doctor or through a physician. This is the usual care. Okay, so we choose because there is a poor outcome in the real world setting, and while on the clinical trials there is a good responses for this medication. Okay, so there is an optimal practice or suboptimal treatment, and there is a problem in medication adherence, and also there is a problem with the self-care. So what is the self-care? In a simple, the self-care to activate the patient to be an active member on the treatment. Okay, so the patient also can become an active member for the treatment of heart failure. So this is a gap here. You can see this is also alarming study. So there is a suboptimal practice. This is a multi-center study, included more than 2,000 HFrEF patients. There is only 22% and 12% achieve the recommended dose for the ACE inhibitors and for the beta blockers. You can imagine here, there is only 12% of the patients on beta blockers, and they did not achieve the target dose. So it's mean that there is no mortality benefit, there is no hospitalization benefit for these patients. And this done in Europe. This is a multi-center in Europe. So you can imagine in our settings, it could be quite horrible. Okay? So at the end, the drug known to improve the outcome either not prescribed in a target dose or not prescribed at all. So this is our main problem. For this, to solve this problem, we have a philosophy of disease management program. Anyone know about this philosophy or this concept? Anyone know or have any experience about disease management program? What is this? Yes. So the disease management program, it's included 3 modalities. So number 1 is the heart failure clinic, number 2 is a home care, and number 3 is a telemonitoring. And in this short presentation, I just taken about the heart failure clinic, and this is compared to the usual care. So the disease management program as a heart failure clinic are effective in optimizing patients with heart failure. So we increase the dose to the target dose, we increase the adherence to the patient, and also we increase the self-care of this vulnerable patient. Now, the heart failure clinic as a concept is not something new. The first heart failure clinic is started on 1983, and at the beginning, it's led by nurse. And the first heart failure clinic is just optimize the care for 15 heart failure patients. Those nurses, just they act to optimize the treatment or to achieve the target dose for the patient. And you can imagine, this is a job for the pharmacist. Sahih? Is it a job for the nurse only? So this is our main job. So the multidisciplinary heart failure clinic, it includes physicians, nurse, nutrition, social workers, clinical pharmacists, and other type of specialty. Okay? So the first addition of the clinical pharmacist to the heart failure, it's occurred in 1999. So the first clinical pharmacist added to the heart failure clinic after pharm study. And I'm just recommend for those who are interested on the cardiovascular clinical pharmacy, just go and read about this study. It is a pharm study, which is a quite inspiring study. Okay. Now I'm talking about our setting in Sudan. So this is the first heart failure clinic in Sudan. And you can see these dates. So on December 2014, and then after 1 year, and then after 4 years. So I'm start negotiating the idea. This is my scatter thoughts to establish this clinic in Sudan. And on 2015, I'm start a formal contact with the authority in Sudan to start this clinic. However, alhamdulillah wa shukr lillah, it's just came, we start after 4 years from the negotiation. Okay, so you can see, because there is a lot of challenges when you want to convince, and I think the setting is similar here also. When you want to convince the authority in OMEOCH to establish something led by clinical pharmacists and not led by solely by physician. Okay. We start on June 2018 with 1 patient, and we stay for 2 months, and just there is a 4 patient coming to the clinic because of different reasons. Okay, reasons from referral from the physicians, this is number 1. Reasons from the patient, because it is a new idea. And just the last statistic, we're crossing the 1,000 patient. Okay, so we start with nothing, and we end up with crossing the 1,000 patient. So the team is included 7 specialty. We start with consultant cardiologist who takes the full responsibility, and we have a clinical pharmacy specialist, and we have also clinical dietitians, and we have cardiac rehab team. All those are included, and all of these have defined role, and there is no overlapping between roles. When the patient enters the clinics, all of these specialty know his or her own job and what to do. This is the referral criteria. I'm not going to go through that. There is a clear referral criteria from all units to refer the patient to our heart failure clinic. And this is a journey from the patient after the referral made by the consultant cardiologist. And there is an appointment with the heart failure clinic. And then we start the titration. This is the job of the clinical pharmacist mainly. Titration to achieve the target dose, because we want to achieve the target dose to reduce the mortality, to reduce the hospitalization, and all of these bad prognosis. And after 6 months, maybe the patient is discharged from the heart failure clinic backward to their treating doctors. So this is a journey from the heart failure clinic. And in Sudan also, the clinical pharmacies are not allowed to prescribe medication. And also they are just allowed to change the therapy if the treating doctor is accepted. So we did a protocol. This is one of the registrar in cardiology, and this is a consultant cardiologist. And we did a protocol adopted from the guidelines. At that time, adopted from European Society of Cardiology guidelines and also from the American Heart Association guidelines. And this protocol allows the clinical pharmacist in the clinic to do the job of the prescriber and to do the job of the changing on all of these issues. Okay? And this is one of the role of the clinical pharmacist. The main role is to identify the drug-related problems, and then also treatment titration to the target dose, and also to improve adherence for patients with heart failure. Okay? And this is also nurse intervention, because the nurse is the first one to contact in the clinic. So we have a nurse intervention, and they are mainly acting to increasing the knowledge about heart failure. This is in an attempt to increase the self-care of the patients. And you can't imagine the patient, even they didn't know the basic symptoms of the heart failure. Okay? We have education session. We are also establish a teaching book for the patients with a simple Sudanese language, so everyone can understand the instruction. And also we assess the knowledge and we assess the self-care. And this is a book in Arabic, and even not Arabic, it's in Sudanese Arabic language. It is a very simple. I saw some of Sudanese here, I think. Okay? So this is one of the case. This is the first patient coming to the clinic. And this patient, she diagnosed with a HFrEF for 3.5 years. And you can imagine this patient is on lisinopril 5 milligram, and the target dose is 35 milligram. And for 3.5 years, these patients, they took this medication. She is on bisoprolol 2.5, and the dose that decreased the mortality and hospitalization is 10. And she is on spironolactone OD. Why is the dose that decreasing the mortality and hospitalization is 50? So we did a lot of job to target, to increase the patient's dose to the target. And at the end, this is a very short presentation, and at the end we did a lot of publication so as to increase the awareness of our community about heart failure. So we start with this paper, which is the first multidisciplinary heart failure in Sudan. We describe all things in this clinic, from the roles, from multidisciplinary team. And also, we published this article, which is including clinical pharmacy's intervention to improve titration for the prognostic medications or the pillar medications to the target dose. And this is also first experience from Sudan. And also we end with this article, so clinical pharmacist intervention to promote medication adherence. Also a lot of job done in this. We did the service at the beginning, and then we took the data for the publication. So the publication is not our ultimate goal, but just after that we can take the advantage. And also, this is regarding the nurse. So also we publish data regarding the knowledge scale. We use Dutch heart failure knowledge scale. We translate it to Arabic Sudanese language, and we use it after maybe this is recent published, I think last month or something. Okay? So by this, I end this short presentation, and this is my reference. And if you have questions, maybe on the discussion part, thank you for your attention.
Thank you, Dr. Kannan. And what is really inspiring is the initiative taken by him to start that heart failure clinic, and also emphasizing on the importance and introducing clinical pharmacists in that healthcare team, So this is really inspiring. I hope we get message and we can initiate more such healthcare initiatives in Oman system also. So thank you again. And now we have our last speaker for today, Dr. Arif, who will be speaking on Beyond the Numbers, how improved overall survival transforms the endometrial cancer journey. So just a brief about him. Dr. Arif is a medical oncologist physician with over 20 years of clinical experience. He is an assistant professor of medicine in Sultan Qaboos Comprehensive Cancer Care and Research Center. He has authored more than 100 publications in international journals and actively has contributed as a reviewer for leading medical publications. He chairs the Multidisciplinary Tumor Board and leads quality initiatives as the department's oncology quality manager. His commitment to global health was recognized with the United Nations Medal in 2008. And Dr. Arif Zaribi is a member of ESMO, ASCO, IGES, and which reflects his deep engagement with the international oncology community. So we are looking forward to hearing his experiences at Sultan Qaboos Comprehensive Cancer Care and Research Center. And thank you for joining us today. Thank you.
Assalamu alaikum. So I want to start by thanking the Oman Pharmaceutical Society. This is the first time as medical oncologists we are presenting with doctors, but this time it will be with pharmacists, which is very nice. So we'll change completely the topic. So we talk about antibiotics, we talk about heart failure treatment. Now we change. So I am a medical oncologist. So I am treating cancer patients, and I am focusing in treating gynae cancer patient. So I'm in daily practice, I am treating cervical cancer, uterine cancer, and ovarian cancer. So today and in the few, so today and in the few 30 minutes, I will try to present for you a new treatment which transform the outcome of patient with endometrial cancer. This new treatment changed completely, because comparing to what we did before, and this is a chance now for our patient to get this new treatment. So endometrial cancer is the most frequent gynae malignancy, with more than almost more than 400,000 cases diagnosed worldwide. This is a statistic of 2020, and the number are increasing year after year. And the mortality rate have been increasing almost by 2% every year. So 15 years back, we have like two endometrial cancer. We have type 1 and type 2, and this is dictated by the histology. But the recent year and the research show that there is at least 4 molecular profile of uterine cancer. I will present this in the first slide. The bad thing is that in advanced stage, which is stage 3 and stage 4 means that disease go out of the uterus and spread in all the body. So for this patient, unfortunately, the 5-year survival is only 17%. This is so like 10 years back when we treated this patient, after 3 years, almost more than 50% died, passed away. So we need, this is what make research, and we need a new treatment to enhance this survival. So this is some statistic from the region, as you can see in this slide. So here, Kuwait and Bahrain. So the incidence rate is almost 8%, with a mortality rate of around 2%. For Oman and Qatar, the incidence is around 3-4%, and the mortality is around 1%. So since this study, this is GOG 209, this is like 15 years back, the only solution we have is chemotherapy, which is 2 treatments, paclitaxel and carboplatin. And unfortunately, we have only progression-free survival of 1 year, and the over survival is 3 years. So the patient with stage 4 will live for 3 years, and after that, we lose much of our patient. So that's why we need a new treatment to enhance the outcomes. So I said before, for uterine cancer, now the new research showed that we have 4 molecular profile, which is in these small boxes. So we have the POL-E. The POL-E is a mutation. So if we find this mutation in the cancer itself, this is 10% of our patient. This is a very, very good prognosis. If the patient had uterine cancer with this mutation, he will live longer and longer, because this type of cancer with POL-E mutation, they are well infiltrated by our immunity system, which can prevent cancer cell to progress. The second group is the MMRD. MMR for mismatch repair deficient, which means that cancer cells cannot repair DNA. These also have a good prognosis. If a patient is DMMR, this is good news, because he will respond to the new treatment I will talk later on. The next one is P53 mutant. I don't know if you hear about this mutation. This is a very, very bad mutation. In whatever type of cancer, if you have this mutation, P53 mutant, this is poor prognosis. So if a patient have P53 mutant, we know that outcome will be bad. And if the patient is not belonging to POL-E, MMRD, P53, we say this is no specific molecular group, and this is 40% of our patient. And what the recent data, like this very good publication by Hewitt et al. In 2015, they check this group of patient DMMR. I said if you have DMMR, which means MMR deficient or microsatellite unstable, this is good news because this type of tumor, they are well infiltrated by T cells, and there is a very good neoantigen load, as you can see in the circle, red circle. This is the MSI, this is the MMRD. If you compare with the MSS, which is not DMMR, they have a very good infiltration by T cell and very good neoantigen load. And as well, a very good infiltration expression of PD-1 and PD-L1. And as a doctor, we use this biomarker PD-1. If the tumor is expressing PD-1, this is a predictive factor to response to immunotherapy. So this type of tumor, DMMR, they are the best candidate for immunotherapy. And if your body is infected by virus or bacteria, so there is activation of T cell, right? But who will tell to the T cell to stop after bacteria is gone or viral infection is gone? So we need something to stop T cell, activation of T cell, to avoid this autoimmune disease, because if T cell kill cancer cells or kill bacteria or virus and continue to activation, it will lead to autoimmune disease. So we have this checkpoint like CTLA-4, PD-1, and this checkpoint, if they are activated, they will tell T cells to calm down. Khalas, the virus is gone. So you can calm down. So this checkpoint inhibitor. Why I am saying this? Because the cancer cells are smart. When they are in your body or the body of the patient, they know that T cells are their enemies. And they know that if they activate this checkpoint PD-1, they will stop cancer cells from killing them. So this is what happened in cancer patient. So this is the cancer cells. She will go to interact with T cells through PD-1, and this is a negative interaction because PD-1 activated. This is a checkpoint. So T cells will go in anergic state or frozen state, and cancer cells will have time to grow since T cells are sleeping. And this is the new treatment we have now. So if there is a negative interaction between T cells through PD-1, so what we need, the solution is to block PD-1 to avoid cancer cells to activate PD-1. And this is the new treatment. It is immunotherapy. And today I will present dostarlimab, which is a PD-1 blocker. So since it blocks PD-1, it will allow T cells to attack cancer cells and avoid this anergic and this frozen state. So we have, for the data now, we have these 4 studies that test. So if I have stage 4 uterine cancer, which is mean metastatic uterine cancer. So I said years back, it was only chemotherapy. So now the new treatment, we introduce immunotherapy plus chemotherapy. This is our first line. So we explain to the patient that we will give you chemotherapy and immunotherapy. This is our first line. And now we have 4 studies that showed the efficacy of combination of immunotherapy plus chemotherapy. The first study is the RIBI Part 1 study with the new drug. I'm talking about dostarlimab. Second study use another immunotherapy, which is Pambro. The third study, atezolizumab, you can forget this study. This was a negative study. And the last one is DOE. All of them, they are using immunotherapy, but different immunotherapy. So for the first study, for which study we have primary outcome, right? When you do a study, when you present a new treatment, you need to have an outcome. So the primary outcome of this study, and this is the only study that have this outcome, which is overall survival, which means overall survival. This is the ultimate outcome. If the drug will improve overall survival, it means your patient will live longer with this patient. And this is what we want and what the patient want, right? So this is the only study with this primary endpoint. As you can see in the other study with NRGG 018, there is primary endpoint is only progression-free survival. Durvalumab, same, and atezolizumab was negative. So the question that proposed this study, Ruby, is does the patient live longer with this new treatment? This is the question of the study, and this is very important. For the histopathology, there are some differences between the study, but Ruby study, this is the only study that includes carcinosarcoma. This is 10% of the patient carcinosarcoma. Carcinosarcoma is very aggressive histology. If your patient has carcinosarcoma, this is bad news. And this study studied this type of aggressive histology and to test this new treatment on this aggressive histology, and this is the only study that have carcinosarcoma. As you can see, for the if patient received, like it was a local treatment, he received a local treatment, and after a month, unfortunately, we discovered that in the follow-up that there is metastasis. So the good thing in this study, Ruby, that it allows an early inclusion of the patient. So as you can see, if the patient progresses after 6 months in this study, he's allowed to be included in the study. Compared to other study, we need 1 year. We cannot include a patient that progresses in 6 months. It needs to be 13 months or more. And there is some differences between the duration of treatment. For dostarlimab, it's 3 years. So if I will start treatment, it will be for 3 years. I will explain to the patient that I'll give this treatment for 3 years. For the other study, it's 2 years, and for the last one is until progression, so there is no limit. So as you can see, you remember this group dMMR. This is the good news. This is the best group. As you can see here in the bottom, progression-free survival and overall survival has a ratio 0.2 or 0.3. What does it mean? This means that this new drug, which is dostarlimab, for example, it is decreasing by 70% the risk of progression and death. It reduced by 70% the risk of progression and death. And in the pMMR, which is P for proficient, it means it is not dMMR, so it is pMMR. We have a response lesser than the MMR group, but still has a risk of 0.7. So this is 30% reduction in the risk of progression and death. And to focus in the study, why this study? So this is the only study that have this primary point, which is over survival, which means does the patient live longer? And this is the only study with mature data. I presented for study, the only study with mature data. It means they finished the statistic and they had a final conclusion about the treatment is this study, Ruby. So Ruby, they include patient with stage 3 and 4 or first relapse endometrial cancer with all type of histology. I said carcinosarcoma was there, which is aggressive histology. They randomized 1-to-1 to get dostarlimab plus chemotherapy, followed by maintenance treatment of dostarlimab for 3 years, or to receive only chemotherapy plus placebo, followed by placebo. So this is what we did like 10 years back. This is the control arm is our chemotherapy that we used 10 or 15 years back. Experimental arm, we add this new treatment, which is dostarlimab. So dostarlimab will be used with chemotherapy for 6 cycles, and after that, we stop chemotherapy because we cannot use chemotherapy for 3 years. It's very toxic. So we'll stop chemotherapy and continue for 3 years with only immunotherapy. And the primary endpoint is progression-free survival, but the most important thing is overall survival, and we need the response to the question, does patient live longer with this treatment? If they doesn't live longer, this is not good for the patient. We need patient to live longer. So as I said, includes stage 3, stage 4, aggressive histology are there. For the baseline characteristic of population in this study, as you can see, most of the patients are pMMR, dMMR 20%. Most of the patients in stage 4, advanced stage and 3, and carcinosarcoma, I said this aggressive histology is 10%. Here we have the progression-free survival in the overpopulation. What does it mean? So in all comers, whatever type of histology, whatever of type molecular profile, is there reduction of risk of progression? What means progression? It means in the follow-up, because when we follow the patient, we do CTs. And if there is progression in CTs, which means there is a new tumor, a new mass, spread of the disease, progression. So for all comers, all patients, we have a benefit. It was positive progression-free survival with a hazard ratio of 0.6. This is statistically significant results with a reduction of 30% of risk of progression. So if you take this new treatment, which is dostarlimab, whatever patient, all comers, all uterine cancer, whatever histology, you have 36% reduction in the risk of progression. It means the patient will stay free of any disease and continuous follow-up. If you take the dMMR group, this is the best group, this group with good news. Check there, hazard ratio 0 to 8. This is 72% reduction in risk of progression. So if patient had dMMR, this is a very good news, because if you give dostarlimab, you will reduce risk of progression by 72%. In the pMMR group, always this is the group with less response, but still there is a response, and it is statistically significant. It's 24% reduction of risk of progression by using this new treatment. But now the most important thing. You remember the question proposed by Ruby. Does the patient live longer with this new treatment? The response is yes. And this is in the all comers. Whatever type of histology, whatever molecular profile, if you give this new treatment plus chemo, followed by maintenance for 3 years, you will patient live longer by 16 months. This is a fantastic result. So we are saving life with this treatment. This is in all comer. If you see here in the dMMR group, in the evaluation at 3 years, 78% of patients, they are still alive, comparing to 46% only in the chemo. Say we are almost doubling number of patients after 3 years of treatment. And we are saving, like if you compare two curves, we are saving more than 30% of patients from death. And in the pAMR, less, always less, but there is a still benefit. Patients live longer by 7 months in this group. The most important is 16 months. So all comers, all the population, whatever type of histology, there is a benefit. Patients live longer by 16 months in all comers. This is in Ruby trial. They tried also to check molecular profile patient, and when they try to analyze over survival in the different molecular profile, they find, regardless of molecular profile, there is benefit from giving this new treatment. And for the NSME group now, when I started, I see at least 4, because in the future maybe it will be 5 groups with ER and positive and negative. It's good to give a treatment that make patient live longer, but what about safety, right? What about the safety? If it is toxic, maybe patient don't accept to live longer with toxicity, right? Huh? So for the safety, we have more like 10% more toxicity in the dostarlimab group, which makes sense because they will receive 3 years of treatment. They are under treatment, so there is toxicity. What type of toxicity? The most important toxicity is rash, skin toxicity. And if we try to, for grade 3 toxicity, the differences between the two arm is 10%, more 10% toxicity in dostarlimab. But check here, so for the advanced event, the more frequent or hypothyroidism, rash, arthralgia, and liver impairment, and this is a manageable toxicity. We are prescribing immunotherapy for many, many years, so we can manage easily this. So for hypothyroidism, we'll give hormone replacement, and for rash, we give like topic. It's not like serious or toxicity that we need to stop the treatment. We never stop the treatment. We give the treatment, and we treat in the same time the side effect. The most important thing for us, a medical oncologist, when I prescribe this new treatment, dostarlimab, I know that the patient will develop toxicity while he's receiving chemo only for the 7 first cycle. So in the 7 first cycle, I am vigilant, I am proactive, because I know that most of the toxicity will happen in this 7 cycle. After 7 cycle, most of the toxicity is down. So if the patient will come to receive 8 cycle, I said to him, khalas, finish. Toxicity now will improve because your body is now adapted. So most of the toxicity happen while he's receiving first and 7 cycles. What about quality of life? So they study, this is a secondary endpoint in this study. They check quality of life, and quality of life is improved. Why it is improved? Because there is no progression of disease. Patients stay without any progression, so there is no progression, there is no pain, there is no like ascites, there is no quality of life is improved by using this new treatment. And not only this, they try to check if the patient progress on this new treatment, he will get another treatment. So the question was, did this patient will benefit from the second treatment? And the response is yes, because there is this PFS2, which means if your patient progress, he will get a new treatment. If he received before dostarlimab, he will benefit surely from the next treatment. So there is PFS2 benefit. So to conclude, we have mature data. This is very important. We have over survival benefit. This is the ultimate outcome. The most important thing in the study is over survival, which means does patient live longer? And the response is yes. So after 3-year follow-up, patient live longer by 16 months, whatever, all comers, all patient, you give this treatment, you have 16-month benefit. They live longer 16 months. If they are pMMR, they have less response, but still there is benefit. The best group is dMMR, and for now, over survival is not reached, which means patients still get benefit from this treatment, and at 3 years, we already save 32% of patients. Just to summarize, if you have 100 patients, if he is dMMR, you will save 70 patients. If he is pMMR, you will save 20 patients. And if he is for all comers, you will save 30 patients of 100 with this new treatment. And this treatment now, it is approved by the NCCN, this is the American Regulatory Society, so with a recommendation, grade 1, this is the best recommendation to give this treatment, and it is approved and it is approved in all comers, since there is benefit in all comers in this group. So they didn't say give it to this group and not to this group. No, all comer. And same in the European Medicine Agency, EMA, it was approved in Jan 2025, and it was approved for all comers. So now the question, since we have a very good response with the immunoratral, question was, why giving this chemotherapy 6 cycle? Why not delaying chemotherapy and give only immunotherapy? So we have now 2 studies. They are recruiting. We are waiting for result. This study will give a first line without chemotherapy, only immunotherapy. And the study with this new treatment, dostarlimab, is Dominica. So we need to follow the study to get the result. Is so a first line free of chemo, only immunotherapy. It will work or not. And this is to show you that maybe it worked because this patient, different type of cancer, rectal colon, endometrial is there, it is in green. So they give them this new treatment, dostarlimab, for 6 months, and they discover that giving this treatment by itself without any chemotherapy, disease disappear. 90% of patients were in complete response, no cancer after 6 months of this treatment, but they need to be dMMR, the best group. You remember dMMR. So my conclusion is that the combination of immunotherapy and chemotherapy now is the standard of care of treatment of endometrial cancer. This study showed PFS improvement, but the most important thing is over survival in all patients and with mature data, and it includes aggressive histology. This slide just, I will tell you a story about this empathy. So because as a doctor and regulatory, we are taking decision without including the patient in our decision. So I remember one of my patients, like 10 years back, I explained her a new treatment. And I explained that this new treatment will make you live longer by 7 months. It was another treatment. So she smiled to me and she said, I remember this word right now because it was emotional. So she said, maybe this 7 months for you is just a number in a paper, but for me is one more birthday, one more Ramadan, maybe I can travel to Umrah, and why not I can be present in the graduation of my son. So we need to think about the patient perspective, because sometimes you are saying, no, 7 months is not enough. It's enough for the patient is meaningful. So we need to bring some empathy in our decision and include the patient. And finally, when prescribing this treatment, you are not just treating cancer, you are giving patient a real chance to live longer with their family and loved one. This is my last slide. Thank you.
Thank you, Dr. Arif, for an excellent presentation where he mentioned about different stages and combination of immunotherapy with chemotherapy and the benefits. So I would like to invite now all the speakers on the stage, and so we have an opportunity to ask them questions, or to, if you have any clarifications, you can ask them. So I invite Dr. Yaman, Dr. Kanan, and Dr. Arif on the stage, please. Yeah. Actually, it was such a nice session, starting from antibiotic stewardship to the heart failure clinic to management of cancer. So anybody would like to ask the questions from these speakers? Yeah. Actually, I can see somebody, Dr. Majid, you want to ask something? Okay. Actually, I would like to ask one question to Dr. Arif, because you have mentioned about this combination. So can you just mention about what is the cost effectiveness, and did the treatment was economically viable? Because you mentioned 7 months and also about 13 months. I know it means a lot to the family and to the patient, but what about the economic
Yeah.
budget or
So
economic
there is
burden
many-
on the
Yeah,
hospital?
because when we propose a new treatment in our center, we have a committee for that. We need to approve. So when we go to the committee, the first question is cost effectiveness because very, very expensive. But there is many studies that show that this new treatment is cost effective because when you give the treatment, you have no progression. So you have no more cities, more other treatment since the patient is receiving one treatment. So if you give this treatment for 3 years, and as I present, if you can see after 3 years, there is plateau in the curve. So this patient in the plateau, most of them, they are cured. And they don't need any treatment. So this treatment will avoid any progression, other treatment, yes. And there is in the data, in scientific data, that show that it is cost effective, yes.
Now, it's cost effective, okay, fine. But now, what about those 7 months? You increase the lifespan, but what was the quality of life in that 7 months, you know? Because you know that if you have 7 months to live, it's also a mixed response, you know. So person's quality of life, was it really changed? Was a person feeling better?
So
or-
7 Life, this is in the PMMR group, in only a subgroup of patient. So in all comers, you have a benefit of 16 months. But 7 months, this is only in the PMMR group. And the quality, I show only one slide, but there is many slides about quality of life. They check pain, they check fatigue, they check every aspect of quality of life, and it shows that quality of life is improved with this treatment. Because this is not chemotherapy, this is immunotherapy.
Immunotherapy, yeah.
So when you start immunotherapy, you get the toxicity within this 7 cycle. After that, some patient, they are asking, what you are giving me, this is only water, because there is no toxicity after 7 cycles. It's not like chemotherapy, which is very toxic. Immunotherapy is less toxic than chemotherapy.
But when you saw those people, because, okay, fine, one way you gained those 17 months or 18 months, but at which stage they again the health conditions started deteriorating? Because obviously they could not live longer than that. So that means there must be some deterioration also which
Yeah,
happened,
so
no?
16 months is a median, right? So
16
it
months was
is-
the...
is a median, is a
Yeah.
median, which means there is patient that live maybe 30-month benefit, there is patient less than 16, so it's a median. So there is patient that will progress, we cannot do anything, but I show that even if they progress, when they receive another treatment, they will get benefit from this treatment, because there is PFS2 benefit, which shows, it was showed in this study. So 16 months, it's fine, because if we compare this, what we did like 10 years back, we are losing 50% of our patient after 3 years, and when they progress, there is no option. Now we have many options.
Absolutely,
Yeah.
absolutely. Thank you so much.
Yes. Assalamu alaikum. Can I ask?
Yeah, please, yeah.
I'm Dr. Majid. I have a question for each. Is it
Yeah,
possible?
please go ahead,
Right.
you know.
Dr. Yaman, you showed something which is interesting, where you mentioned that there is delays in taking the sample to find out the resistance. Have you tried to explore what's going on? I mean, was it a problem in decision making, or a problem in communication between the sample taker or the physician, nurse? What's going on? Then you have the prescription pattern. I wonder, is there any multiple drugs prescription in these, what you surveyed in these prescriptions, or these only single types of cephalosporins, or multiple types of? Have you also explored what type of or how many drugs, antibiotics prescribed in these prescriptions? Are these the same cephalosporins? Or you mentioned mostly cephalosporins. I don't know. Is there any other in combination? I don't know. Is there anything related to resistance to these drugs? Dr. Kannan, I don't know, you forgot or you just, I don't know, success rate. What kind of success rate you achieved with your clinic? And what was the reason of such achievement? Challenges, مثلا? And then Dr. Arif, regarding the treatment, factors such as female age, was there any influence of female age in getting good results, bad results? Was there difference between young female, old female? Stages, cancer stage. You mentioned one slide. I did not see it much. You mentioned like stage 1, 2, 3, 4. I did not get it actually. Yeah. So, is there any factor influence of these stages over the success of treatment? That's all. Thank you.
Thank you, Dr. Majid. I will start. You asked me two questions. The first question was regarding the timing of the culture and sensitivity testing. Okay. The total isolates were 3,000 plus, and then those included inpatient to outpatients and referral as well. So the timing of the sensitivity, since it's a retro study, and it was, so we included, to come out with these findings, we included only the inpatient sensitivity testing, okay? Because we couldn't able to trace the one from outpatients. This number one. So the one included in this sub-analysis was around 1,000 cases for the timing. Again, there was some missing data, but the average we found is about 4 days plus. Your question was the possible reasons. Possible reasons, since it's a retro, so we couldn't find, this one, it has to be a prospective study, then only we can answer this part. But we took, like after discussion with the team, so sorry to say, but we noticed that they are keep throwing the blame. Is it the microbiology department, or is it from the order? There was no order given by the physician, or is it microbiology department? And even the time, even if the sample taken, according to guideline, it should be, the results should be out within 48 hours. But again, this one maybe I didn't show, but even the results were delayed more than 48 hours. Yani sample taken wrongly after a few days, and then even the time until you get the result is even delayed by the lab. So it's a good question for future studies, for prospective studies. Yeah. But since it's a retro, so we cannot answer that part. Second part, with regard to the prescription rate of cephalosporins, actually we did, but I didn't present in this part because we didn't it just finished the first part, and we are still continuing the other prescription rate of different antibiotics. So what we did, each class of antibiotics separate, and then whether there is a combination or no combination. But the one complete so far was the cephalosporins. Cephalosporins, there is no combination from different groups of cephalosporins. So one cephalosporin, but yes, it was combined. Depends on the case because the guideline different. So different disease, whether 2 or 3 or from which, depends on the sensitivity and susceptibility of the antibiotics. Different reasons. Number one, for example, the nature of the pathogens. And number two, the severity of the disease, whether it's a mild or moderate or severe cases. So if mild, usually they will go for a single therapy. If more severe, then they will go for a combination of 2 or 3, even 3. Thank you.
Okay, thank you, Dr. Majid, for the question. So regarding the success rate, there is a multifactorial answer for that. So I can answer it can be qualitative success and quantitative success. The qualitative success, the idea to addition of clinical pharmacy to a multidisciplinary team, this is one of the big success. This is number one. And for quantitative, for the role of the clinical pharmacist, we did more than 4 articles there. So number one, the titration of the prognostic medication to the target dose, and we did achieve this significantly for most of the medications that reduce the hospitalization and mortality. This is maybe need one presentation. And number 2, also we increasing patient adherence solely by the intervention of clinical pharmacists. We did the educational intervention. Also, this is second articles, and this is also quantitative. And also we increase the knowledge of the patient about heart failure. And this is maybe the second quantity success rate. In fact, all these 3 interventions, it reduced the mortality, it reduced the hospitalization, but we fail to assess the mortality because maybe it's need more prospective studies. But the hospitalization is quietly reduced. The quality of life is quietly improved. Okay, so this is a success from the, but it need maybe another presentation to have like that. Okay, thank you for your question.
So I cannot remember. So the first question was about age. So for age, uterine cancer is the cancer of postmenopausal women. So most of our patients are 60, 70. So there is no young patient. We didn't have 20 years old. All patients are 60, 70, and even in our daily practice. But the best thing that immunotherapy, there is no contraindication related to age. We are giving immunotherapy to old patients. We got immunotherapy even to CKD patient. I have one patient, she's CKD, she's doing dialysis. You can prescribe immunotherapy for this patient as a monotherapy. She's uterine cancer and CKD, and she's treated. We cannot give chemo, but we can give immunotherapy, and she's still in response. For the stages, the study, there is only stage 3 and 4. 3 with measurable disease, which means like after surgery, there is a residual disease, or 3 with aggressive histology, you can include your patient. And I didn't show the forest plot, but in the forest plot for PFS and OFS, all subgroup, the response to the treatment, regardless stage or regardless. Yeah, it's for stage 4. It's for metastatic disease. No, it's so whatever type of meds you can prescribe it. You can prescribe it for all comer. You will get benefit, more benefit in the best group, which is dMMR, mismatch repair deficient. This is the best group. Until now, over survival not reached. It means we cannot calculate it. It's still, patients are still gain it, or maybe they are cured if they are dMMR. If they are in the other group, there is less response. But the conclusion is in all comers, regardless whatever stage, molecular profile, you have this 6-month benefit, and with no safety signals and very good quality of life. I mean 16 months with very good quality of life, yes.
So, first of all, my name is Assam Youssef. I'm a pharmacist in the background, 1999. I'm very happy to be here with this huge group of pharmacists. And I'm the market access lead in GSK. Very happy to be part of this wonderful event. And thank you for the partnership from the association to give us the chance to sponsor this event. Actually, I'm commenting here because I'm talking to pharmacists, and I know your question was very, very relevant question, considering that we are coming with a costly medication to be added to the treatment of endometrial cancer patients. So how economically this is being addressed? First of all, and before anything, that dostarlimab is being reimbursed across most, like 32 countries across the globe in all HTA agencies. So it's been scrutinized and discussed thoroughly through the cost effectiveness and budget impact analysis through a very complicated system. Unfortunately, in our region here, still we don't have this kind of advanced health technology assessment to assess such kind of cost effectiveness to the thresholds and to the quality or to the qualities. Having said that, we got many studies. I have one study in hand now that it shows 5.6 quality life years, considering the previous data, the progression-free survival 1, not even 2. So if we go with 2, this would definitely increase the life years. So we have thoroughly data about that. We just wanted to confirm for the audience here, because it's a burning question with all of us. We are pharmacists who are dealing with the cost and we all do stuff. So we need to get the strong rationale about that. So from the cost effectiveness perspective, it's a cost effective medication considering the alternative options available in the market and considering the chemotherapy itself with the additional overall survival and progression-free survival too. I might be biased because I'm a GSK, but the studies are here. So if anyone would like to have those studies, I can reach it out for you. So thank you so much again for giving the opportunity.
Assalamu alaikum wa rahmatullah. This is Dr. Mohammed Al-Ghazali from College of Pharmacy, National University. First of all, I would like to thank all presenters for the more valuable presentation. And my question to Dr. Arif, who will take the opportunity since he is the physician, actually expert physician in the field of oncology. I have just two simple questions. I take the opportunity to ask you this question. What is the role of clinical pharmacist from the view of expert physician in the clinical management for cancer disease? Second question about the role of anti-cancer resistance. Is there any updating information that highlighted the view for the resistance therapy of anti-cancer related to endometrial cancer disease? Thank you.
So for the clinical pharmacists, so in our daily practice, we are always working with clinical pharmacists. They are our friends. So when I put order, so before putting order, so it was validated by the committee. After the committee, they go to the purchase and the new treatment like this dostarlimab will be available in our center. So now we'll call the clinical pharmacist to discuss this new treatment. It's a new treatment for me and for him. So we need to explain how it was given to the patient. We are following the Ruby trial. What done in the Ruby trial, we tried to do it in the real world. And the clinical pharmacist will upload the protocol in the HIS that I can confirm it to the patient. So we discussed together, because here there is two phases. There is phase with chemotherapy, which is given at the dose of 500 milligrams every 3 weeks. But in the maintenance treatment is only dostarlimab with 1,000 milligram. We double the dose to complete the 3 years. So we are to start the process. We discussed together, and there is a very good collaboration with clinical pharmacists. And when we have this side effect, we communicate again, because we need to treat the cancer as well as the side effect. Because if you didn't treat the side effect, the patient will stop the treatment, right? So we need to treat the cancer, treat the side effect. So the response is they are our friend, and we in our daily practice, we are collaborating with them. For the second question was about resistance. So what happened? So if I give a treatment to a patient, so I will get a response, let's say, first 3 months. I will continue, say, treatment. So after 6 months, I do a CT, and there is CT progression, right? So what we did, and this is what we need to do, is to take a new biopsy, because progression is a molecular progression, which means cancer is acquiring a new mutation. When you give a drug, you have a clone of cancer cells that develop resistance by acquiring a new mutation. So I will do NGS, new molecular profile on this new mets. So I will go to the, like, if I have new mets, metastasis, I will go to the new mets. I ask the radiologist to take biopsy from this new metastasis, send it to the molecular lab, and I will get the report, what is the new mutation. And if I have the chance and the patient says, I will have a drug for this mutation. I can target this mutation. If I can find the mutation, but I cannot target, I cannot give a treatment. But most of the time we find mutation and we prescribe the treatment that target this mutation, and we can get more 3 months of response, 3 months, until we'll get a new mutation. And this is our daily job. So response, progression, change the treatment, and we gain in PFS, to hopefully get the OS, over survival. So this is our daily job. So we give treatment. If we have a response, we continue same treatment. If progression, new biopsy, check new mutation, try to target this new mutation. And so this is a cycle. This is our job.
Can I ask you a simple question? Because Oman is known for many phytoconstituents which are reported to have effect on, or actually they're helping in progression of cancer. Have you done any research on phytoconstituents in your cancer center? Like phytoconstituents which are plant-based products like Akba and resveratrol. So these are certain products, maybe it's a new thing for you, you know, but a lot of research is being done on phytoconstituents also in the management of cancer. So are you doing any research also along with the treatment?
I didn't study herb in medicine, but the first thing before starting treatment, I will tell my patient, don't use any herb, please. Because when, I will know, because when patient came with liver impairment, AST, ALT 1000, I know he's taking some herbs. So the first thing I will say, don't use herb, please, because they will interact with chemotherapy, and we have liver impairment, so we are not using herbs. And yes, many of patients ask us, well, what about these herbs? What about herbs? My response is very clear. I don't know anything about herbs.
I remember a case from Khawla Hospital. I remember there was a doctor in Khawla Hospital, and she came to our college and gave a presentation that when no treatment was working, she herself started working with that Akba, you know, and also some plant constituents which are available in Salala, and she could have a miraculous recovery and she could completely get rid of the cancer, you know. So that's what I'm asking that, because there are some studies from Oman about the products which are available. So yes, she published that work. Yes, from Khawla Hospital, and she actually spoke about her journey and how with the help of plant products she could actually, frankincense, she was working on frankincense product, and she found remarkable recovery with that, you know. No, I totally agree, but that was her personal experience, so that's why I'm asking that, have you... Curcumin, yeah. Curcumin is like, there are a lot of reports on curcumin, you know. Yeah, which is, obviously, curcumin is antioxidant activity, and a lot of research has been done on curcumin, you know, and different targeted formulations with the nano-emulsions and that, you know. I have only one question to Dr. Yaman, because you talked about Buremi, you know. So you did study in Buremi. So like in Khawla Hospital, they mentioned that they've already incorporated that WHO system of AWARE, you know. So when they prescribe certain antibiotics, then automatically it shows that for this disease, they cannot prescribe those because antibiotics are classified as excess and then watch and then reserve. So are they following this in Buremi also? Do you have any experience with that?
Not yet. The antimicrobial stewardship even just started, just initiated recently. But this was the future, to include the AWARE and then see whether is it matching the global trend or different for the local practice. Thank you.
I think that will be really an excellent move because Khawla Hospital, they've already set up a model. So it can really help in controlling the antibiotic use, you know. So any questions, please? Yes.
Thank you for this mixture of topics. Like I can say, Kenan and Arif talked about two of the most mortality-causing diseases. And when we are talking about AMR, like a competitor, the coming competitor by 2050, we can say it will be the first top death-causing issues in the world, and we have to think about it. And we have to have initiatives like what they have in Sudan for the heart failure. And it will not be easy. Like it took them maybe 4 years, maybe it will take more than that. And we work in the field for more than 20 years. And when you have any initiatives, you have to be patient until you get your goals. Just like I have one question for Dr. Arif. You talk about like 15 years old, we had just like we heard about the chemotherapy, and now we are talking about MABs and monoclonal antibodies. So we are in, I can say, a quick-paced world. And we heard nowadays about the ATMP, Advanced Therapeutic Medicinal Products. Looks like, I can say, the T-cell or CAR T-cells. And we heard like the university now, Sultan Qaboos University, they started, I think, one of the first trial there. So if we can talk just like a brief of it. And when we are talking about like the quick-paced world, I mean like most of the audience here are students, so we have to be like equipped with all these advanced technology because you are now in a world of competition for the job. And you have to have like this knowledge about all the advances in all the fields, like, and about all the diseases and treatments. Thank you so much.
So thank you for this question. So yes, so this new generation of treatment, they are there. So we are using this in the second line. I talked about first line. So our first line is chemo plus immuno. So what about patients that progress later on, maybe after 3, 4, 5 years? So like I said, I will do biopsy. And many patients, they express HER2, which is a molecular profile. And now we have a very good new treatment. The family is ADCs, anti-CAR drug conjugate, which means this is antibody that carrying chemotherapy. So the antibody, the role of antibody is to go to these cancer cells, and it will be like inside the cancer cells, and at that time it will liberate chemotherapy. This is a new drug called trastuzumab deruxtecan. So the new generation is these ADCs, which are antibody carrying chemo and going inside the cells, but you need to have a biomarker, which is the target of the antibody. You need the antigen, which is HER2. So we have a study that showing that if cancer cells express this HER2, you can give this drug as a second line. And for CAR T cell, they start in hematology, as you said. We didn't start CAR T cell because this is a new technology. You need machine, you need logistic for that. But let's see, this is the future. And for us as a medical oncologist, we are happy now to have this ADCs, anti-CAR drug conjugate, which is giving a very, very good response. So now, like this uterine cancer metastatic stage 4, with all the treatment available, they can live 4-5 years, which was not the case like 10 years back. And not only in uterine cancer. So now breast cancer, colorectal cancer, metastatic from the beginning, they live for 5-6 years. If someone said that 10 years back, they will not believe that. But with this new technology, this new treatment, we have a very, very good response. So the problem is regulatory to approve this treatment, that they will be available here in Oman to use, when we start, for example, dostarlimab, we follow, this documentation, this administrative thing to start it. So for the first patient, it took 3 months to start the treatment. But it opened the door for the next patient. But starting is always, but we are using this new generation. What we have available, we are using them, yeah.
Do you have any questions from our young pharmacists? Okay, if you don't have any questions, then I would like to thank all our esteemed speakers for sharing their experiences and enlightening us with the new advances and what is happening in different parts of Oman. And I'm sure with the intervention and with the inclusion of the clinical pharmacist, the progress in handling medications and handling antibiotics, and also introduction of that heart failure clinics, maybe we will all be seeing this in the near future, that pharmacists will be involved. And again, thank you so much for joining us. And then, thank you so much.
Thank you, Professor Alka Ahuja, for moderating the session, and thanks for the speakers for these useful talks and discussions. You may be seated. I would like now to invite Dr. Ali Al-Farsi, the director of the Central Drug Analysis Laboratory and Drug Safety Center, Ministry of Health, and Professor Majid Abu Khadr, the chair of Industry and Community Engagement Committee. To honor the speakers, firstly, the moderator of the session, Professor Alka Ahuja. Firstly, the speakers. Okay. Firstly, the speakers. Dr. Yaman Qassab. Dr. Kannan Omar. And Dr. Arif. we would also like to honor the moderator of the session, Professor Alka Ahuja. And, and thirdly, we would like to honor the sponsor of today's session, GSK Pharmaceuticals. And now we would like to give a token of appreciation from the College of Pharmacy to the Oman Pharmaceutical Society as a thank you for hosting this event.
And we'd like to thank the host of today's event, pharmacist or student? Okay, student Ihan Al-Azzawi. Thank you very much.
Actually, I would also like to thank Ms. Maitha, who is also our faculty member at College of Pharmacy, for taking care of things. She was at the backstage where she was taking care of all the coordination in last few days. So a big round of applause for pharmacist Maitha, our faculty member at College of Pharmacy.
Thank you all for attending this session. Please take a moment. There will be giveaways now for prize draws.
نور محمد العبري. ريام المعمري. حليمة المعمري. أيوب المحروقي. And the last one. عبد الرحمن الحارثي.
Thank you all very much for attending this event. Inshallah, we will see you more in the coming events of this club. And please, you may now go and have dinner. Thank you so much.